Hello and welcome to the first of a series of tutorials where we're going to be covering the anatomy of the cardiovascular system. Now over the course of this next 5 or 6 tutorials we're going to start with some of the very basic cardiovascular anatomy, build on that with a little bit more complexity and a few more clinical points, and then we'll finish it off with a look at the cardiovascular histology and some of the anatomopathology of common conditions that you find within the cardiovascular system in the context of a few clinical cases. So in this first tutorial then, we're going to review some of the very basics of cardiac anatomy, and then we'll look at the position of the heart within the body, and a term that we refer to as the cardiac axis, which is important in understanding ECG and a variety of other concepts in cardiology. And then finally we'll look at some plain chest radiographs, some real radiographs, and we'll look at how we interpret those to give you an algorithm that I try and follow, and then finally we'll look at the cardiac silhouette and what that means. Now, the cardiovascular system is essentially a muscular pump that's attached to a variety of pipes or blood vessels. Now that muscular pump is responsible for delivering blood to the peripheral organs and tissues, or perfusing those organs and tissues, and in mammals it exists as a dual circulation network. Now we exist as mammals and we are endotherms, which means we're responsible for generating our own body heat, and the dual circulation network is an adaptation for that, and we'll look at what that means in a bit more detail shortly. So remember that the heart is a muscular pump. It works actively, which means that it consumes energy and so requires a rich energy source. It's a very metabolically active organ, and it's responsible for carrying nutrients and metabolites to and from tissues respectively. Now, I've already mentioned that mammals possess a double circulation network. What does that mean? Well, it means that we have a circulation system that goes to the lungs and from the lungs and to the peripheral organs and back again. Now that pulmonary circulation, which involves the heart and the lungs, is responsible for oxygenating blood. So we'll look at the network that blood takes shortly through the heart. But the pulmonary circulation serves the function of oxygenating blood with new oxygen. Gas exchange with carbon dioxide occurs at the site of the alveoli in the lungs, and then it's responsible for delivering that freshly oxygenated blood carried on the hemoglobin molecules within the blood itself, within the red blood cells, back to the heart for delivery into the systemic circulation or peripheral circulation. The peripheral circulation system essentially involves the left-hand side of the heart, and this delivers blood to the metabolically active tissues, and then those tissues return it to the heart on the right side. So you'll commonly come across in medical textbooks the terms left and right circulation. Left circulation is generally referring to systemic or peripheral circulation, and if you see a textbook talk about right hand circulation, then that's referring to the deoxygenated side of returning blood to the heart and back to the lungs respectively. So do remember that we have a double circulation system, and this is really important for oxygenating the blood. Now, one of the things that it's easy to get confused with in this setting is the actual blood supply to the lungs itself. The pulmonary circulation isn't responsible for delivering blood to the lungs in terms of its own metabolic needs. We'll revise that a little bit later on when we talk about the respiratory system. But remember that the pulmonary circulation is there to oxygenate blood, the peripheral or systemic circulation is there to deliver blood to the peripheral tissues. So some very basic cardiac anatomy then. We're looking at an anterior view of the heart, and we're looking at its external features. So here we can see the superior vena cava, which is delivering deoxygenated venous blood from the head and the neck. You can't see on this image the inferior vena cava, but the two are really intrinsically linked. So the superior vena cava brings blood from the head and neck to the right atrium, and the inferior vena cava brings it from the lower limbs, etc. This large structure is the arch of the aorta, and it's the principal source of all arterial blood. It's actually coming from the left ventricle, which we'll see shortly, And on the right hand side of the body, we first get a common arterial trunk, which is known as a brachiocephalic trunk, that then splits or bifurcates into the subclavian artery and the right common carotid. So we have the right subclavian artery and the right common carotid artery. Now the subclavian artery is going to supply the upper limb on the right hand side. The common carotid artery on this side is going to supply the head and neck on the right hand side. If we then go over to the other side, we can see the left common carotid and the left subclavian, and the important thing is these two come directly from the arch of the aorta. Now that's a textbook teaching. That's what a textbook of anatomy will tell you. Be prepared for the fact that if you're performing open heart surgery, a patient might have an anatomical variation. Not everybody's aorta is going to be built in this way, and some people have sort of abnormal branches of the arteries. They have additional branches of the arteries that never cause them any problems, and they may die with them and it won't cause their death. They'll be perfectly fine with these additional arteries. And for instance, I've seen examples of where the vertebral artery comes straight off of the arch of the aorta, and that is an example of one of those additional branches that would never really cause a particular problem. The advantage of having a bifid or bifid circulation is the fact that you can preserve circulation on either side. This structure here is the pulmonary trunk, and it's wrapped round. The aortic arch wraps around, it sort of hugs the pulmonary arch or the pulmonic arch, and it sits just next to a structure known as the left auricle. But essentially, if you're getting a bit confused as to which is which in any sort of spot test scenario, just look for that sort of arch hugging the pulmonary arch itself. So basic cardiac anatomy then. We know that the heart consists of 4 chambers. First, blood comes from the inferior and superior vena cava into the right atrium. It passes through atrioventricular valves into the right ventricle, comes up through the pulmonic valve into the pulmonary arch, where it will then form the pulmonary arteries that go off into the lungs to be reoxygenated. That reoxygenated blood is returned first via the pulmonary veins or pulmonic veins into the left atrium, left ventricle, and then through the aortic valve up into the arch of the aorta, where it will be delivered into the peripheral circulation. So that's the network, the pathway by which blood takes. And this is a particularly nice ultrasound image of the heart, where you can see the atrioventricular valves closing and wafting away there. It's particularly nice to look at it like this. It's living anatomy. This is what you would see on a heart ultrasound. There's also a cardiac imaging known as an echo, which we'll deal with later on in this series. So where is the heart then? Well, the heart actually sits hidden away between the lungs, and that cavity between the lungs is known as the mediastinum. This central cavity is almost the core of the thoracic cavity. This region here is known as the mediastinum. You'll hear textbooks talk about mediastinal masses in young children, for example. Tumours can occur in this region. The mediastinum is a critical area. If you just look at that diagram for a few seconds, you can see how many major structures we have in there. We have all the great vessels, which is collectively referring to the aorta, the pulmonary veins, etc., the pulmonary artery, sorry, etc. We have key nerves passing down to the diaphragm through that zone. So this is a critical area, and the heart sits bang in the middle of it. Now we split the mediastinum, so what we're looking at now is a lateral view of the mediastinum in a schematic sense, and we split it into different regions. So this is like we've taken the thorax, separated it from everything else in the body, and now we're looking at a lateral sagittal section view of it. And we split it into superior portions, which is above the heart, posterior portions behind the heart, the middle portion which contains the heart, and the anterior portion which lies just in front of it. Now I should say that the anterior portion is relatively unremarkable, or it should be. And so there's not really much to say on that one. But there are different structures within these regions, and it's important to know which ones lie where. We have in the superior region all of the great vessels. So the arch of the aorta is found here. We have the subclavian arteries, all the main branches that we've just talked about. The thoracic duct, the thoracic inlet is in this region, which is the portions of the rib cage or the thoracic cage that contribute to that upper thoracic aperture, communicating with the head and neck and the thorax. Then we have the anterior portion. Now I've put here thymus, lymphatics and adipose. The thymus is an immunological organ. It's a primary immunological organ that's mainly found in young children. The thymus is important for T-cell maturation. It can be present in abnormalities as well. And the anterior mediastinum is relatively unremarkable. In the middle we have the heart and its surrounding connective tissues, the pericardium. We've also got the very roots of the great vessels there. So obviously the arch of the pulmonary arch is there, the beginning of the arch of the aorta is there. The posterior aspect contains the descending aorta, esophagus, thoracic duct. Now they are also found, which is not shown on this image and it should be, in the superior region of the mediastinum. Now there is a junction between the superior mediastinum and the rest known as the angle of Louis. This is covered in the tutorial notes, but the angle of Louis is at approximately T4, T5, and that marks a number of important features, including the position of the great vessels, the arch of the aorta, the bifurcation of the trachea into two, etc., into the primary bronchi, etc. So the angle of Louis, or the sternal angle, sitting between level T4 and T5, is marked by that horizontal line just below the yellow portion, just below the superior mediastinum. So now we're going to look at the position of the heart in the body. Now, everybody will have at some point bumped into somebody that says, oh, hand on heart, and they usually place it over the pectoralis muscle on the left hand side. Of course, that's not the position of the heart. The heart lies in the middle of the mediastinum, which we've just discussed. But now we're going to look at the way the heart is oriented. Many textbooks describe this as a pyramid being laid on its side, and that's how I've chosen to represent it here. Now, it's not quite a pyramid because it's got too many sides to be a pyramid, too many borders to be a pyramid, but you can roughly see a pyramidal shape if you look at it from this orientation or this direction. So if you trace a line from that top corner to this apex portion, imagine that's the apex where the arrow is pointing of the pyramid. It's roughly a pyramid being thrown on its side. Now that apex point is called the apex of the heart. It's touching the very tip of the heart, and we call that the apex point. And this is an important anatomical landmark because it's the site of what we call the apex beat. Now the apex beat lies in the fifth intercostal space, roughly within the mid-clavicular line. So if you count 5 intercostal spaces down, roughly in the mid-clavicular line, you'll find the apex beat. This is an important landmark because if you can palpate an apex beat there, that's pretty good. That means the heart is probably about a normal shape. Of course, it's going to vary in individuals of different ages and different sizes. But if that apex beat were to migrate further down, then intuitively you can tell that this is shown the heart must have enlarged. So sometimes you'll be able to palpate the apex beat in the patient's mid-axillary region because it's migrated round to that left-hand side. So this is a marker of enlargement of the heart, which we technically refer to as left ventricular hypertrophy. Borders of the heart. All of those faces of the pyramid are going to form what we call a border of the heart. And there are different chambers at those different borders. So these are now talking about the sides of the pyramid, which is effectively talking about these borders of the heart, which contribute different chambers. So this anterior surface faces the sternum and the costal cartilages, so it's called the sternocostal surface. This is the first of 3 surfaces of the heart. And on this surface you can see we've mostly got right atrium and right ventricle. So on the anterior surface, the sternocostal surface, we have the right atrium and the right ventricle. Done. That's the anterior surface. Posterior surface is sometimes confusingly called the base. Traditional textbooks call this the base, but that can be a bit confusing because you automatically want to go to the bottom of this screen. Actually, it's the posterior surface, the bit that's essentially facing the patient's back. This is mostly made up of the left atrium, and it's here where the pulmonary veins are going to drain in order to deliver that freshly oxygenated blood into the left atrium. So the left atrium forms the posterior surface. The diaphragmatic surface faces the diaphragm. The heart actually sits on the diaphragm. It's called the diaphragmatic border of the heart, And it's actually continuous with it to some extent because we have connective tissues and fascia that are all connecting it to that particular zone. And this is made up of ventricles, the left ventricle, the right ventricle. So you can see that the orientation of the heart is not intuitive. You can't just pick it up like you would in a dissection room and orient it so you can see both chambers facing you, etc. Actually, what we've got when we look at the anterior surface of the heart is the right atrium, right ventricle. Sitting underneath that, we have the left ventricle and right ventricle on the diaphragmatic surface. Then posteriorly, we've got the left atrium. The best way to know that is to get in the dissection room and hold the heart at the orientation that it would be. There's no better substitute from that. But looking at that image, right now, what we are facing is the right atrium on the left-hand side of the image and the right ventricle on the right-hand side of the image. So the borders then. Talk about the borders, which are the edges. Either side, we've got a lung, so we call these the right and left pulmonary border, respectively. Quite intuitive. Right pulmonary border, left pulmonary border. These are abutting what we call the pleural cavities where the lungs are. The inferior border is referred to as the diaphragmatic border as well. Doesn't really matter. Why is that important? That was a lot of information, seems relatively useless. It's not useless because when you're looking at an X-ray, you can't look at an X-ray. X-rays are beyond the visible light spectrum. However, we could refer to them as radiographs. When you look at a radiograph to the chest, then you need to know which bits you're looking at. Now, the majority of chest radiographs are usually taken from posterior to anterior, what we call PA, rather than AP, which means that the X-ray generating source, the X-ray cathode, is situated behind the patient. On this particular slide, patient's looking towards the right-hand side. X-rays are fired from the patient's back to an X-ray film at the front. The X-rays are fired through the patient. The X-rays are fired through the patient from back to front. Why do we do that? The reason that we do that is because we get an image that looks like this. Everything is in the right proportions. Now, you will adopt your own mechanism for being able to interpret a chest radiograph. I follow an ABCDEFG algorithm, which I will roughly go through here very quickly, but I'm going to focus in a second on the cardiovascular aspects. But what you should always do when you're looking at a chest radiograph is look at that image and say to yourself, when was that taken? Why was it taken? Who is it an image of? That's the most important thing. Before you start to look at any of the anatomy that's there, before you're a keen bean and start dipping your head into saying, oh, they've got clouds on the lungs, they've got this, they've got shadowing here, and not important. What's important is that the person that you're presenting this image to understands when it was taken, why it was taken, and who it was taken of. So that's really important. Remember to look at the orientation that it's been taken at. It will usually tell you, we've told you here that this is a PA. I use A to stand for airway. So you can actually see on here what we call the tracheal shadow. So you can see here this tracheal shadow. This is the trachea here. You might just be able to see its bifurcation occurring roughly along there. I don't know whether you can see my cursor or not at this point. The B is for bones. Look at the bones. Are the bones normal? You can see the scapulae here, you can see the clavicles, you can see the vertebrae, you can see a lot of bones on this. Look at the ribs. Can you see anything? Follow them. Do they look abnormal? Do they look osteoporotic? Do they look like there might be something going on there that's not nice? So B I use to stand for bones. C is relevant to this tutorial. C I use for the cardiac silhouette. So the cardiac shadow. That is this structure here. So this big mass is of course the heart. It's situated a little bit to the patient's left. The cardiac silhouette, the first thing you want to do is look at its size. Does it appear to be normal? Well, we're going to cover that in a second, so we'll come back to it. But just look at the shape of the heart. Does it look particularly normal? Is it displaced? Is it where it should be, etc.? Remember now that we can mostly see the right atrium, the right ventricle when we're looking anteriorly. We can see certain features that I'll come back to shortly. D I use for the diaphragm. If you look just below that lung shadow there, you can see a very sharp line where the image then becomes very bright and white at that point. That is the diaphragm. It should be a very thin, defined line. If it isn't, there might be some air in there. Those are all the things that you need to look at. E, empty space. Are there any empty spaces here? Are there any particularly abnormal traces to do? F, because I'm going through this quickly, I can't remember what F is. But G stands for the gastric bubble, etc. You can just see down in the bottom right-hand corner where the stomach would be some little shadowy areas where there's some air from the stomach, etc. Let's not worry about that for now. Let's focus now on the cardiac anatomy. But that's a brief algorithm. Hope that sort of thing's useful to you as a clinical tool. Now, cardiac silhouette is there. What else can we see? Well, we can see the aortic knuckle. This is where the arch of the aorta is. So what level roughly is that going to be at? We know that the aortic knuckle occurs at the angle of Louis, which is roughly going to be about level T4, T5. So it's going to be roughly about that level, we know that much. We can see the left auricle here. We can see the not the left auricle, pulmonary arch there. That is the pulmonary arch. Ignore the idiot that wrote this tutorial, which is me. That should be the pulmonary arch, okay? Do apologise for that one. It will be corrected in the handouts. Right ventricle is mostly making up this here. Inferior border of the heart is there, and you can see that sharp line between the diaphragm. If you're lucky, on the left-hand side of the image, on the patient's right side, you might just be able to see the edge of the inferior vena cava, but you'll be very lucky if you do. Now, what we now want to look at is that cardiac silhouette again. The main thing that I'm looking at here is what proportion does that shadow take up of the whole thorax image. That is known as the cardiothoracic ratio. And what it should be is about half. So it should be taking up about half. Here, it looks as if it is. So I would say that that's normal. The normal cardiothoracic ratio is 0.5. Therefore, that's what we talk about there. So cardiothoracic ratio is a measure of how enlarged the heart is. So in that slide there, we've covered quite a lot of information. We've covered an algorithm that you can use in order to interpret chest radiographs. Be very careful to call them radiographs. Some radiologists will really pull you up on the fact that you can't see an X-ray. No, you can't. It's outside the electromagnetic. Well, it's on a non-visible portion of the electromagnetic spectrum, but it's a point of contention for some people. The chest radiograph or chest X-ray, we've gone through an algorithm how you can solve it there, and we've gone through the main cardiovascular features that you can see on that X-ray. This is why we don't like to take them in an anterior-posterior form. Now, sometimes patients will need to take them from forwards to backwards because they can't physically support themselves. For example, in this case here, we can see this patient is obviously not well. For a number of reasons, but mainly because you can see there's some ECG leads here. So this patient is being monitored for something. So look for those sorts of clues that already tell you something about this patient's picture. The next thing that you want to look at is the size of the cardiac silhouette. That is pretty big. This is a particularly large patient, but what you can see here is that that cardiac silhouette is particularly big. Now, this is probably because that patient is not well. However, what you should be able to see is the fact that it's enlarged in the AP plane. So the reason we don't like to take them in the AP plane as much is because it enlarges the cardiac silhouette, and that can lead you to make false assumptions or false deductions from that. That concludes the first tutorial. So that's been very brief, very basic. In the next tutorial, we're going to look at the chambers of the heart. We'll look at specifically at cardiac anatomy in a little bit more detail, and we'll be focusing entirely on the heart itself. So what we've covered, the cardiovascular system consists of the heart, great vessels, peripheral vasculature. System works to deliver oxygen and essential nutrients and to remove metabolites, and we talked about double circulation. The heart is positioned and makes up the middle mediastinum, so we talked about the mediastinal divisions. Importantly, it consists of three surfaces, anterior base or posterior and diaphragmatic, and those borders, which were the pulmonary and the diaphragmatic. And then when we look at the heart and chest radiographs as a cardiac silhouette, we can see them better, well, a more accurate representation in a PA view. So that was the end of the first tutorial. I hope that you found that useful, and very shortly we'll have the second one up for you. Thank you.